Good afternoon and welcome. Thank you for joining us today. I'm Samantha. I am the Director of Member and Partner Services for the Texas Association of ACOs. We are excited for this opportunity to present to you our next installment of our webinar series, Overcoming Constraints to Value-Based Care, sponsored by The Garage. Before we get started, I'd like to go over a few items so you know how to participate in today's event. You will see a user control panel on your computer desktop. You can listen in via your computer speakers, or if you would prefer to join over the phone, just select the arrow above the audio over the audio button and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing your questions into the Q&A tab. You may send these in at any time during our presentation. We will collect these and address them during the Q&A session at the end of today's presentation. With that, we are excited to have our business partner, The Garage, and hand it over to Pranam, who is leading this presentation today.
Samantha, thank you for that introduction and thank you for the handoff. We are very excited to be part of this webinar. And on behalf of my two partners on the call, my colleague Jessica Robinson, our Chief Platform Officer, and a very esteemed customer executive, Joe Taylor, who's from Holy Redeemer, we truly appreciate this opportunity to share our experience, to share our journey, and hopefully be able to drive a more meaningful dialogue towards democratizing value-based care, which is extremely important in today's times. But before we get started, I want to first congratulate every ACO that generated savings across the country. The results just came out yesterday, and the MSSP ACOs have generated a record amount of savings for the CMS Medicare Fund. And that's just fabulous. It just puts everything in perspective. It excites everybody at The Garage. So everyone on the call that has been part of this journey, congratulations. And the new ACOs, the new entrants, be excited of what's to come, because I believe the next year will be another record-breaking year for all participating ACOs. So with that, I'm going to share my screen and then we'll get the presentation started. So let me get that going. Okay, awesome. So this is the topic of conversation today, where we're looking at how do we overcome constraints to democratize value-based care. And when we talk about quintuple aim, when we talk about health equity, when we talk about the need to bring in real change for underserved communities, what we're trying to do is to basically democratize this notion of value-driven care. So to everyone that took the time to be with us today, thank you. And let's do some quick introductions out of the way. So I'm Pranam Ben. I'm the founder and CEO of The Garage. Jessica.
Hi, everyone. I'm Jessica Robinson. I'm the Chief Platform Officer of The Garage. Thanks for joining us today. And I'm really excited that the ACOs are taking that step to really focus on the data in order to drive their value-based initiatives.
Joe.
Hi, Joe Taylor. And in this role, it's the president of the Community Care Collaborative and our clinically integrated network, the Innovative Wellness Alliance, out in the Philly area.
Thank you, Joe. Thank you, Jessica. So let's get into this. So the way we came at this is to look at sharing just 10 principles that we, as a platform partner with Community Care Collaborative and Joe's team, have applied these principles, these philosophies, these solutions over the last 7 years to bring in real measurable change. So everything that you're going to see in the next 20 to 25 minutes is all born out of hands-on experience of doing the work that it takes to bring in change and to drive success in ACOs. So the first thing, and we'll talk about this, we've all been challenged by this. For those that have been in healthcare for however long, data interoperability is a moving target, has been our biggest challenge since the advent of EMRs. So for now, the way we look at this is that what was the challenge is today the catalyst for change. So there is a real transformational shift in the way we look at data, in the way we look at what's available. So in the partnerships that we have enabled from a garage perspective, we have actually committed, we are obsessed about solving for data availability. In fact, we have the saying that if you as an ACO store your data in the dishwasher, we'll go get it. We are that obsessed about enabling the data access, normalizing the data, aggregating the data. So once you solve for availability, you then look at how can you make it portable? How can you make it available, actionable where it matters at all points of care? Today, the reality of healthcare is it's not one-dimensional. It's not a one-size-fits-all. It's not a one service provider-driven experience. So you're looking at how can you activate the most meaningful data in the most meaningful way where it matters. And that journey starts with enabling the centralized data warehouse that is able to normalize data across sources, across formats, across sizes, across types. And that has been our fundamental approach, a data-first approach to solving for data interoperability. So that is the first nugget, the first principle that we built this entire journey on. For the second, Joe, if you want to kindly, give us your thoughts on this.
Yep. So just as a little bit of a background, we have generated shared savings all 7 years of our ACO. We've gotten paid 6 years and have an average of about 5% shared savings earned. This year, and I'm sure all of you have started to digest the public use files that came out yesterday, we were, and I'm just going to look here to make sure I don't mess up, we were 80th percentile in PA-based ACO. So any ACO on the file that said they were in PA, we were the 80th percentile in shared savings as registered by a per member shared savings, a per beneficiary, 65th in quality. Of the ACOs in PA, only 3 did better in both quality and shared savings. And that's where this becomes really important because, you have your anchor program, something like post-discharge follow-up. But to get continued success every year, and this year we are at 6.8% shared savings, you got to start mining the data and looking for those other things. And so for us, we built an algorithm with our friends from the garage on what we call the priority patient. And that algorithm is set not necessarily for people for care management, but people we want to bring in because we can close those care gaps, because their coding seems insufficient, because they have a high use of ED. And so year over year, you have to keep looking and learning from the data to let it direct where you are. And so when you're looking at high performance, 1 year is pretty easy. 2 years gets a little tougher. 7 years, it's pretty hard every time.
And Joe, just to add to that, the work that Joe and his team have done with their ACO is a role model for ACOs that are looking to adopt a data-first approach. So even outside of this webinar, I would encourage everyone to reach out to Joe and he's someone who will happily share their experience, their wisdom, as they've done with us over the last 7 years. So I would encourage every ACO to contact Joe. He's available on LinkedIn and the contact information is available via this webinar. So he can continue to share his knowledge and his experience with us. So moving on to the third principle, this is for Jessica to weigh in with her point of view. Jessica?
Thanks. So what we're saying here is that we need every payer, every provider, and every patient governing and kind of taking reins of their patient health. The saying that it takes a village to raise a child is the same as in the healthcare world. It takes a village, it takes lots of discipline, it takes various specialties, it takes primary care to kind of drive that holistic care of the patient. What we've done at the garage is really look at the framework, which you see in the bottom right-hand corner of your screen. For population health, you have to understand the data. We have to have advanced analytics. We need to know what's going on so that we can drive those little pieces of change that are really going to make a difference, especially when we're talking about year-on-year savings. Risk and performance management. Understanding what is the risk of our population, understanding what is the performance of our providers and how do we ensure that we're driving the right performance metrics for the right portion of our patients. Care management, that's huge. A lot of care happens when the patients are outside of the primary care office. So how do we get everyone to talk to each other and not worry about losing the patient to A or B? At the end of the day, we need to understand that the patient is that person at the end of our line of communication, regardless of whether they're in our office or not. So all getting in together and really understanding how do I help this patient in a holistic setting is really going to make sure that we're embracing our understanding of the patient and we're communicating with all entities across that care continuum.
Thank you, Jessica. And the one point to add to that is that every ACO that has ever begun their journey and committed to value-based care, the journey is always evolves into more than an ACO, right? You start as an ACO, you place your bets in the program that is well established, being the flag bearer of the value-based care movement. But eventually, it's a matter of time. Even Joe had the same experience. It's a matter of time before you expand and you take on risk with other providers, other payers, other patient populations, and you look for horizontal standardized strategies that will allow you to be successful, because that is what is going to take for us to be able to democratize value-based care and scale the strategy. Thank you, Jessica, for that. For the next one, I'm going to request Joe to talk about how we have aligned or how they have aligned the network and the providers and operationally being successful. Joe?
So going back to what Jessica just said, it's about the data and being able to use the data to actually make fact-based decisions. Now, our ACO is a little different than maybe some. We're owned by a health system, but we have a profits interest for the physicians, and about 80% of our physicians are independent, not employed. And so I think in a lot of ways, we behave more like a low revenue physician ACO, always looking for ways to look at specialist referral patterns, look at the efficiency in the hospitals, looking at which surgical docs do the most post-discharge follow-up, looking at home care. When is it ordered? How well did it work? What's the readmission rate for home care? Preferred SNFs. We have the SNF 3-day waiver. Are they using them? Are those SNFs doing what we've requested of them? And so there's a lot of information and a lot of different network levers. Just those are a few of them. Then on the HCC revalidation, what we call it is chronic condition revalidation. Sounds better. The doctors like it a little better than, coding, right? And what we've been able to do is, one, we know the CMS methods. And so if it's the year before your renewal, that's when you get all the coding to raise your benchmark, right? And so you've got to play the games. You got to know their math. And then the other one is we tell the docs, we want to know this. Yes, we do get, the HCC score lift, but it's really about informing our care management programs so that we know the patient condition so that we can reach out to the right patients with the right information. And we find that helps the docs versus, oh, you're just trying to get more revenue.
Thank you, Joe. And that's a common theme that we see in those ACOs that have turned it around. There is a very objective, tactical, operational oversight on the provider performance at a practice level, and the ability to take that on head on and identify purely on a KPI basis and look for those practices and providers that have a that look at their practice transformation strategies anchored on the realities of value-based care and allowing them to onboard into the ACO and letting them participate and engage and share experiences. Those are the ACOs that have adopted strategies that have allowed them to be high performance. We've had ACOs that initially, when we're struggling to generate savings, and when they're actually objectively looked at their providers from a data standpoint, and then they acted on it, you see the turnaround. It's real. So, Joe, thank you so much for those, for those thoughts. Jessica, just to throw some light on principle number 5, please.
Yes. So this has transitioned and kind of evolved throughout the value-based ACO world. When I started in ACOs in 2012, it was the triple aim, right? It was just better care, improved health, lower cost. Well, then we kind of coined it into the quintuple aim or the quadruple aim, and now it's the quintuple aim. And we actually started having this conversation internally at the garage about that quintuple aim, making sure that at the end of the day, we can lower costs, we can improve healthcare, we can provide better care. But if it's not a sustainable model, it's a one-time fix. It's not going to evolve. It's not going to carry out year on year on year. And then we have to understand that there's health equity. If patients don't have access to healthcare, and this is really kind of driven when we started working closely with our FQHCs, they don't have access to the healthcare that they need. How do we give them this quintuple aim? How do we make the accessible health available? And so when we started looking at this, we really understood that, we have to understand the value proposition and be part of the value add with all of our clients. So we kind of collected this North Star objective mentality, and understanding that at the end of the day, our goals with our clients are the same as yours. And if you're not meeting A, B, or C, we're not meeting it either. So how do we work together and really ensure that we're doing all the things that we need to kind of make this model successful for you, your population, and the distribution of your patients? So this one's been really exciting to see that kind of evolve, having that holistic understanding that at the end of the day, we have to make it work. If we're not going to make it work, and we're not going to take into account all of the different parts of our patient population, you're only going to do so much. And after 6, 5, 4, 7 years, you're not going to be able to keep doing it over and over. It's not going to be sustainable, and patients are going to be left out. So you have to really understand the total population, not just the ones that are coming in your door, and really make sure that you're doing that outreach work to make sure that we have patients and they're getting the care they need, or at least having that outreach touch point to try to see how can we bring them in and how do we maybe go out to them as well.
And if you think about, just to piggyback on what Jessica shared with us, if you think about our healthcare system beyond 2030 for a moment, right? I mean, if you pause and try to reflect on what that would look like, what we quickly realize is that while the ACOs have been the most influential, the most meaningful movement towards real value-based care, that we need to do more. As a community, we need to do more. And kudos to CMS for recognizing that we were championing the cause of quintuple aim, which is kind of like this umbrella vision to say, hey, ACOs are a way to get to this broader strategy, this broader realization that we all need to have in place, and the time is quickly running out. And CMS has realized that. CMS is opening up newer alternate payment model contracts, whether it's the team model or making care primary, bringing in FQHCs into the process of participating in value-based care. These are all meaningful. These are the moves in the right direction to truly help us as a community commit to what we define as the quintuple aim. And once every community in this country has realized quintuple aim in some form or fashion to whatever level of intensity that is realistic given the runway we have, is when I believe, or we all believe, that meaningful change will be realized for our patients. So just thank you for that. Principle number 6 is something that is near and dear to me and to everybody on the call. I am a techie. So I am extremely enthusiastic and optimistic about tech-driven change in the world. So our approach to bringing in meaningful, scalable change in healthcare is to adopt this architecture that we call a digital-first, data-first architecture, or DFDF for short. To enable that, the entire approach is platform-based, but most importantly, where we are grounded in the realities of what we do is everything we do is designed to amplify the human-centric experience of healthcare. There is no amount of tech, there is no amount of data, there's no amount of AI that is ever going to replace the human element, the emotional relationship that patients have with their care teams and providers. And our architecture, our commitment, even our mission statement is designed, defined to enable that. So we're very cognizant, we're very cautious about how we bring in solutions, how we bring in technology and data at the hands of care managers, providers, social workers, the ones that are directly impacting quality of life for our senior populations across the country. So this architecture is what we are committed to. The platform is a reflection of our philosophy that we need to be digital first, data first, but most importantly, we need to be human centric. Joe, Jessica, would you like to add anything on this philosophy, this principle?
I'll say the human-centric part is so critical. I don't want to be taken care of by a robot. I don't want to be taken care of by someone other than someone that can really understand what's going on with me and is thinking about me and all of the things that are part of my life as well, which kind of goes with that sustainability, goes with that understanding the population and being able to have that health equity. At some point, we're going to see tech help guide some of those decisions in taking care of me as a patient. But I want to have that face-to-face interaction. I want to be able to understand that you understand what I'm saying, that you can read my body language, and that we have a conversation, we have a connection. Because when you have trust in your healthcare team, you are going to be more open and honest with what's going on inside of your healthcare world for yourself as a patient, but also externally in what's going on in the environment that you live in as well.
And I would just add to this that, the tools get you a certain distance.
Yeah.
The human-centric gets you the success.
Right.
Yeah.
And so you need the tools because you never get there. But if you don't do the human-centric stuff, you won't get there either.
Excellent. Thank you, Joe. Very well said. The next one, Joe, you are the master of this.
So one of the things is we're really lucky because we have our MSSP ACO, but then we have a lot of commercial and some of those at risk, like our MSSP, Enhanced Track ACO. And so we get a lot of data that we bring into the garage. And then when we're looking at our practices and their performance, it's not just how are you doing an MSSP, but then it's all CMS data. Then it's the local Blue plan, then it's Aetna, then it's Humana, and so on and so forth. So we get a much broader view of the physician performance and actually better than most of the payers for our members. And so we're able to leverage that along with the metrics, which is we got to run this like a business. We forget sometimes, there is a business here, right? If we don't generate shared savings, whoever is leading us is going to sit there and say, now, why am I spending this money? And so it's a business. You've got to know your trends. You've got to have KPIs and see how you're doing towards them, both at the organizational level and then at the practice level. And one of the things, if someone was to say, what is our secret sauce? It's around taking those KPIs and information, going out to the practices monthly and giving them their list and showing them, here's the people who need an annual wellness visit. Here's a 30% that didn't have one last year. Get them in. Here's the people who are upcoming next month. And that's just the AWV, but it's also, the gaps in care. How do we get at those? Here's people who, like right now, our connection, our platform is connected to the local health exchange, and we update it twice a day so the practices know who is or isn't coming in, who's been admitted, who's been discharged, who went to the ED. So these metrics, how much are you consuming this, helps. And that's a really big thing. And then also, just for those of you, and you've probably seen some of this already, but we were able through our data to find those fraud diagnoses. So it started with the catheter, now it's the bags, now there's another one. And we built something with Garage that it becomes very easy to identify when fraud happens. And so again, that's going to help our shared savings and losses because we transmit the data to CMS and we're like, okay, you did the catheter, here's another one, here's another one. And so that will help make the metrics because you'll be able to see, wait, this went out of control, this utilization went up. And so it's real easy to identify those things.
Thank you, John. Basically, the message here is that, and what we've seen as well is ACOs that operate as a real business with revenue and expenditure tracking and with managing teams and managing partners and managing the ecosystem are the ones that continue to thrive over a longer period of time. So, and that's basically what we see with successful ACOs. This is a very interesting, it's a hot topic. Pretty much everyone on the call have heard about some initiatives, some discussion around equitable access to care. Joe, if you can throw your thoughts on this, please.
Yep. So one thing I just want to tell the group is I've lived in Texas for about 30 years. 3 of my 4 kids were born in Texas, in the Dallas area. So I know a little bit about Texas. I have a timeshare in San Antonio still. So I know the different geographies reasonably well. And Texas has a very diverse population. And so when we're looking at this and we're saying there's tech and then there's health equity, it's how do you bring those together to design and get your programs so that you're serving your patient populations? I'm sure if you start to look at your data, you're going to find differences by zip code, differences by disease. We see readmission rates for certain ICD codes. For patients with other comorbid condition, ICD codes, very different by age and so on. And so it's using the basics of this tech equity, knowing the patient before outreach, and then documenting into the care management system what you now know about the patient after outreach so that your outreaches are focused on them. And it goes back to that slide before last where, hey, it's not just about the technology, it's about how do we deliver that to the patient and knowing that the patient's very different in each instance. It's not one patient fits all.
And if there's one thing, Joe, and I'm sure you'll agree with me, if there's one thing we learned from the pandemic, right? Our ability to respond to a crisis, especially when it comes to a health crisis in a community, is anchored so much on how we design cultural relevance into access to care and the ability to have the access for socially diverse and the underserved populations, right? I mean, that was a big takeaway for us. And if we look at the amount of awareness that we have as a community, it stems from what we experienced during the pandemic. And everything that we are thinking, whether we are designing machine learning models or we are designing AI models that will help us scale access to care, I think this has to be ingrained, embedded into the design process, even before you enable any kind of, AI-assisted experience. So the Techquity is this idea that the choice of technology has to be deliberate, given the reality is that there are social factors that impact the health status of communities that we don't have a control on today. And the way to deliver, the way to outreach underserved populations is by enabling culturally relevant care. So that's kind of like a posture on how we want to drive health equity. And we have some amazing partners that not just Joe's organization, but there are many organizations across the country that realize that commit to that, and are actually making real moves. And we are honored to be partnered in that equation. Moving on to principle number 9, and this is something that I think, this is probably doesn't come as any kind of surprise to anyone on this call here. It's great to have data. It's very important to understand what the data is telling you, because raw data is pretty much, it doesn't serve any actionable purpose. But taking that action on that intelligence, regardless of where care happens, and driving that decision intelligence using that data is so essential for all organizations. And that's what we take as our responsibility. From a garage perspective, when we come in, the intent is not to serve your data. The intent is to enable tools that drive intelligent decision making. That's basically our posture. That's basically what our entire platform, our entire culture, our entire innovation strategy is about. And that's what organizations like Community Care Collaborative and every other of the ACOs that we have partnered with that continue to see success in the programs that they participate in have experienced. Joe, anything that you want to add on this one?
You can't stress this enough, that you need the data, but it really comes down to the action at the end. You have to have informed decision making.
Right. Thank you, Joe.
Yeah, I just want to add to that too, is that, data is everywhere. we can give all the data that we have and we can create the visualizations and you can read it, and you can get some insights from it. But if it's not, and sometimes we look at data with a different intent, and what we find is something different. So it's being able to not only just identify what is the key element that I'm looking for from the sources of data that we have, but then also being aware of the other things that data might be telling us that we weren't looking for. What is the pattern that we're finding? And then how do we take the action on it? Because if we're looking for A, we'll find A, and then we'll know exactly what to do. But we also need to understand that there's all of these other things that we find in trends and data. And working with Joe's team at CCC has been great because they're looking at it from different perspective than maybe how we're looking at it. And we're looking at different insights than how they're doing it. So at having that user group of clients that we have, we're all able to kind of really flesh it out. But there's so much information out there, so much data, that the insights are sometimes even overwhelming. So focusing on those 3 or 4 things, those 5 or 6 little morsels of information that are important for that user or for that physician or for that patient, then being able to take the critical action to initiate or to intervene or to help or to guide is so critical in this whole thing. So this is one of my data nerd slides that I love.
Thank you, Jessica. And to wrap us up, last but not least, our 10th principle that we wanted to share with you all, which I think is going to be extremely important, probably our most actionable, most important, nugget to share on this webinar. Jessica, if you want to share your thoughts on this.
Yeah, absolutely. 80% of what patients' health is involved with is a non-clinical element. So I feel like and as I'm listening to kind of everything that's going on, there's a theme with the patient and kind of the village and the communication. At the end of the day, the patient is going to have a genetic factor that we, at this point, may or may not be able to control. There are a few small things. But in general, the care that we give is a very small portion of the overall patient population of their health. So the environment that they live in, we can't always influence some of those things. The lifestyle that they have, we can give suggestions, but we may not be able to intervene. The socioeconomic status, again, helping them to guide them and give them those community-based organization connections to kind of get where they need to go or to help them get that job. But at the end of the day, if we're not looking at that patient holistically, we're going to miss out on things. If we don't understand the health equity that's kind of addressing or kind of intervening with our patients, we need to make sure that we're looking at the whole picture. Every patient is a novel, and it changes throughout their life. So what happened while they were younger may not be how they are as a middle-aged person and then as a senior. And then all of the circumstances are constantly in flux throughout their life cycle as well. So the care team in that care continuum really has to have an awareness and have a pulse of what's going on in the general population, maybe even understanding what's happened historically in their population where they came from, because the environment is so critical to upbringing. How you grew up really does influence how you're going to take care of yourself as you get older. So some of those things can be learned or guided or taught, but unless we acknowledge them, we're not going to be able to address them. And there's some pieces that we're never going to really be able to address. Maybe not in my lifetime, but maybe in our children's lifetime with genetic awareness and genetic testing. But it's such a critical part. And if we're all in it to take care of the patient, we're all in it together, right? We're going to be able to look at it holistically and then be able to help ensure that everyone's communicating. Everyone has the same set of information. Everyone has the same set of data, so that there is that transparency across the patient's health, so that we can all look at it holistically, take care of that patient and that population the way that we need to.
Thank you, Jessica. Joe, do you have any point of view on this?
I just think it's really important, as Jessica said, just to stress in order to really work the patient to do the right thing, you have to realize all these other pieces around it, their environment, behavioral change, socioeconomic, because then you're never going to get to the clinical.
Right.
True. So with that, we've come to the end of this webinar, and just a snapshot of who we are. You see it on your screen. We are a population health management platform company. In fact, I started the business on April 1, 2012, which was the same day that the first batch of MSSPs were formed in the country. So we've had a very harmonious, committed journey with ACOs, and our entire perspective, our entire mission has been defined and influenced by the work that we've done with ACOs, and we intend to continue to that. We intend to double down on the work that we are doing to accelerate and drive more meaningful change. So with that, we'll take a pause and open the floor for any questions that attendees may have towards me or any one of the panelists.
Thank you. That was a great presentation, Pranam. I do have a few questions that looks like they have come in, so I'll go ahead and just get started. And so the first one that I have for you today, how many high performance ACOs are you currently partnered with today?
That's a great question, Samita, and that's what we focus on, right? It's not so much about how many ACOs are able to do what they do. When we talk about high performance, and Joe put that spotlight on those are the ACOs that consistently deliver results. It's not a one-time, performance. It's for 3 years in a row consecutively at a quality score that's higher than national average. We have about 60% of our ACOs that we partner with in that high performance bracket. These are the ACOs that have matured in time. And what's interesting is that about 5 years ago, only 19% of our ACOs were in that bracket. So you've seen this evolution. You've seen ACOs mature in trying to figure this out. And in time, they get better in their operational strategies. They get better in the way they engage and monitor performance through the years. So we have about 60% of our ACOs that are high performance, and with the results that just came out yesterday, I'm waiting for my team to come back with some more details on it. I hope we have a higher percentage once we have those numbers in, but that's a very high number and we're very proud of it.
That's awesome. Next question I have for you today is, how do you get all of the data?
I mean, when we started this journey, which was about 12 years ago, we realized early on that, the biggest problem that we need to solve, which is why this was the first principle we shared, was solving for data availability, right? And this posture that we have, which is whatever it takes, we need to normalize the data at scale on the back end for care teams to see the value on the front end. So we have committed in different ways, whether it is going to the individual EHR or whether going to third-party aggregators that could source clinical data at scale for us. And we have partnerships at scale with Health Gorilla, for example, that are able to feed clinical data at scale to us. We have partnerships with LabCorp that can, so they share diagnostics data, lab data real time with us. We have interfaces with 25 plus HIEs across the country that give us real-time ADT notifications. We have partnership with Experience. So there's a lot of partnerships that we have brought into our ecosystem. So the burden of making that data available and actionable is not on the provider, is not on the patient. That's our responsibility. And that's been our approach. And organizations like CCC, Joe's organization, are a testament to that commitment that we will do whatever it takes to get the data we need so we can analyze and act on it.
And Samantha, I smiled at that question at the beginning because at the end, when we started with this data aggregation and making sure that there was a transparency of information, giving our clients the data, Pranam used to say in sales, if your data is in the dishwasher, we'll go get it. And we really did take that approach, which she kind of elaborated to. We would go wherever we needed to get that data and pull it out. In some cases, it wasn't the easiest process, but at the end of the day, we were able to provide that data to allow for insights and allow for those action-driven workflows. So it was really, really critical to get it. And so we've brought in different partners as we've grown. But initially, those first few days, it was a lot of chart pulling, getting that information, doing whatever it takes to get there.
Thank you. That's very informative. Next question I have for you. How do you encourage provider adoption?
I'm going to have Joe weigh in on that, and then I'll put in my perspective. Joe, what's your response to that?
So there's probably 2 or 3 different things. One, we don't always expect every doc to go out, every PCP to go out to the platform every day. Now, each practice may have 1 or 2 physician super users, But really what we've been able to do is to get what we call a population health champion in the office. And for the smaller offices, they may be doing 3 other things, but we try to get one person who will go to the platform, mine it, and then use that data. The other thing is that knowing that sometimes the doctors, regardless of how awesome the platform is, some won't. We also drop stuff to paper and we do our monthly visits. And then in the monthly visits, the folks will go and pull up the platform and show them the data in the platform. So you got to continually reinforce, hey, here it is, but you can grab it yourself. And so we try to do that. And then the other part is the platform has so much stuff that what we do is we focus on, like, we do these weekly meetings where we only focus on one little topic. And we say, okay, this time we're just going to talk about X, the exchange with the health information exchange. Or next time it might be the care management part of the platform or so on, the HCC coding part. And so it's smaller bite-sized things so that the physician in the practices don't get overconsumed by everything that's in there.
And from our perspective, and it actually plays into what Joe shared, when we look at across the board, and we work with IPAs, ACOs, federally qualified health centers, health systems, the key to provider engagement is to keep it simple and meaningful. I think that's across the board, that's a standard strategy. When you are able to serve, and Jessica alluded to this, those morsels, right? Those tiny, tasty morsels, and keep the physician and the providers away from the complexity of the data, the exhaust of the data, and allow them and give them tools, empower them with a tool chain that they can use to act on demand in a non-intrusive way, you will see meaningful adoption. And the other thing that kind of plays into this is a behavioral aspect of the provider community as well as the incentive, right? What is a real incentive for providers to engage and adopt and to bring in change? Sometimes it's intrinsic, sometimes it's defined by contractual obligations, network participation, whatever be the case, right? So if you can bring in that simplicity, that richness, that meaningfulness of what you're offering to them and club it with a real incentive, we have seen provider communities adopt to these tools and bring in real change.
Thank you for that. The last question I did have for you was actually for Joe. Being a hospital ACO, what have been the specific challenges that you had to succeed as an ACO?
So it's been an interesting journey, and we are owned by the hospital, but about 80% of our doctors are independent. So we really try to behave like an independent doctor-run ACO. So the hospital funds us, the hospital gets certain money depending on performance, but really our IWA board is all physicians from the network except for one person. The CCC board is 80%, and I guess that's not a big deal because, of course, the regs say it is, but is all our physicians. And so they're the ones who are driving our actions in what we do to make the care happen, to get the efficiency. And so we're not necessarily like, oh my gosh, this is going to come out of the hospital money. No, what we're going to be able to do is to deliver money and keep our independent docs happy, who would then help us out by sending us referrals and using our specialists and so on. So it's this, we help them and then they'll help us.
Takes a village.
Yes, it does. Thank you for that, Joe. Mm-hmm. Thank you to Jessica, and thank you to Pranam for presenting this information today. We truly appreciate your partnership. As you all know, this is actually our first webinar as the Texas Association of ACO, so we're excited that our business partner was able to present this information to you all. We will also be sending a follow-up email with contact information, so if you have any follow-up questions or just want some more information, please reach out to us. We also wanted to remind everybody to be on the lookout. We should be making a formal announcement of our first inaugural spring conference for the Texas Association in early April next year. So thank you again for your time today. Thank you to the Garage. We hope you all have a wonderful day.
Thank you.
Bye. Thank you for listening. Thank you.
Bye-bye.